I, Dr. Seema Tandon, on behalf of RRTC team, welcome Dr. Urmila Singh, a senior professor in Gynae Department of KGMU, and all the participants for joining this session on breech delivery and shoulder dystocia. This is a very important complication which we all should know how to manage. Thank you, Urmila ji, for taking out time, and over to you.
Hello everybody. Now we are going to start the session. The first is the breech delivery. You know the breech is the abnormal presentation. So this is the agenda of the today presentation. I will do the demonstration and then the video. So the breech, it is a abnormal presentation and it is the commonest presentation. Commonest abnormal presentation. What do you mean by breech? Normally what happens? The head is in the pelvic region. In the breech, the podalic portion of the fetus is in the pelvic side. And it is the incidence is 3 to 4% at full term. And preterm baby, it is more, incidence is more. So what are the types of breech? As it is a complete breech or incomplete breech. Complete breech means there is the flexion at all joints of the fetus. That is known as the flexed breech. And incomplete breech means there is the one of the joint is extended, and that is incomplete breech. That includes extended breech or frank breech, where the buttock is the presenting part. Footling breech, that is the footling is the presentation and the knee presentation. So these are the things. One is a complete breech. As you see in the picture, there is the flexion at all joints, hip joint, knee joint, ankle joint, everywhere. And the frank breech, there is the extension of the lower limb. That is the extension, flexion at the hip joint, but the extension at the knee joint. The complete breech, that is the flexed breech, is common in the multigravidia, whereas the frank breech or the extended breech is common in the primigravida. So how will you diagnose? The breech is diagnosed clinically as well as by the imaging. The clinically, how will you suspect that this patient is having breech presentation? When you examine, you do the per abdominal examination, you get the hard globular head on the fundus of the uterus. And on the pelvic crape, there is the soft part is there. That is the breech is there. And if you hear the fetal heart sound, the fetal heart sound near or above the umbilicus, and you can, if the patient is in labor, in that case, the presentation, you do the PV examination. If the membrane is absent, you can feel the buttock, you can feel the genitalia, you can feel the feet of the baby. But confirmation is of course by the ultrasonography. If the ultrasonography facilities are not available and during antenatal period, term baby is there, patient is not in labor, you want to confirm the presentation, one X-ray can be done during pregnancy after informing the patient. So the management of the breech, ideally it should be done at the institution or the facility, where the facility for the anesthesia, facility for the operative delivery, and the pediatricians are available. So when you are seeing the patient before 34 weeks, at that time you have to only counsel the patient, because in most of the cases reversion takes place, wait and watch. But you always tell the patient that the baby is in breech. You may I can send you at the facility or the hospital where the breech delivery facilities and the operation facilities are available. So ideally at 34 to 36 weeks, every breech delivery should be as a hospital with the surgical facilities. So always inform and counsel the patient when you are saying that referring the patient to the district hospital or the medical college. So the mode of delivery, how will you decide? Suppose the patient is not going to the district hospital and the medical college. नहीं हमें नहीं जाना है डॉक्टर साहब हमको यहीं रहना है. Hello. Then how will you decide? That is the one is the size of the baby. That is the baby size is less than 3 kg. Pelvis is adequate. Breech presentation is either frank or flex. Their footling presentation and the knee presentation at term is indication for the cesarean section. And patient should be left for the spontaneous delivery when the patient is fulfilling the prerequisite of the breech delivery. Augmentation or the induction of labor is not recommended. If the woman is with a scar, there is a previous cesarean or previous myomectomy or there any other surgery on the uterus, then it is indication cesarean section. And if the woman is multipara and she had vaginal delivery previously, and in that patient, other prerequisites are fulfilled, pelvis adequate, baby weight is less than 3 kg, and it is flexed or extended breech. In that case, you can leave the patient for the breech vaginal delivery. So that this issue should be discussed with the patient and her family and relative. If she is not in labor, and then if she is willing to go, refer her to the heart center, that is the district hospital or medical college, where the facilities for the cesarean section, for the neonatal care and all this are available. So if the patient is not willing, and in that case you have to decide that this patient can be left for the vaginal delivery or you do the elective cesarean section. And they must that the vaginal delivery has the risk to the perinatal mortality and morbidity with the vaginal delivery is high. So always take the consent when the patient, you are leaving the patient for the vaginal delivery. In spite of that, she is willing, then leave the patient for the vaginal delivery if all the prerequisites are full. So what are the indication? As I told you, what are the indication कि आपको खाली उसमें cesarean ही करना है. That is the footling presentation, knee presentation, pelvis is not adequate, baby weight is more than 3 kg, previous cesarean section is there, or when on examination you are getting that the head is very large, that is the extended head is there, they are indicated for the cesarean section. So for the assisted breech delivery, I am going to tell you about the assisted breech delivery. Okay, all the prerequisites are fulfilled. Means baby size average and pelvis is adequate, and there is the baby size is less than 3 kg, no previous scar, then you can leave. And in that case, the patient can be left for the spontaneous labor. During labor, as in the normal labor, and that is the emotional support to be given, IV line to be established, because this patient may land up in the anesthesia anytime. And in these patients, when they are in labor, especially in the breech, ARM should be avoided. ARM is artificial rupture of bag of membrane, because there is a risk of cord prolapses. So the spontaneous smooth labor, only that as in the normal labor you are watching, same is there. Establish IV line and artificial rupture of membrane should not be done in these cases. So now how to conduct delivery? Now the patient in second stage of labor, cervix is fully dilated, fully phase, fetal heart is good. Now bring the patient on the edge of the table, establish the IV line. Then you prepare yourself, and yourself, that is a wash hands thoroughly with the soap and water, put all the attires, that is for the infection prevention. Thereafter, you clean the vulva with the antiseptic and dripping of the mother. Thereafter, catheterize, always evacuate the bladder if it is full. infiltrate the 1% xylocaine at the proposed episiotomy site. Proposed means usually we give the mediolateral. 1% xylocaine कैसे बनाएंगे? Usually the 2% xylocaine is available. For 1% you take the half 5 ml of 2% and 5 ml of normal saline, then it will become the 1%. So before conducting the delivery, always infiltrate local anesthesia in the proposed episiotomy site, because these patients requires the episiotomy most of the time. And don't be hurried to make the woman push. कि बच्चा दिख रहा है, बटक दिख रहा है, लो pull कर ले. No, never pull the baby. Then there is the good uterine contraction. Then you can, cervix is fully dilated. Then you can ask the woman to push, not pull the baby. So how will you conduct? Only you are on the near for the labor. You are prepared for the delivery. Don't touch the baby. Once the buttock has entered the vagina, cervix is fully dilated, tell the woman to bear down when she feels to urge or when there is the good uterine contraction is there. As there is the climbing of the buttock on the perineum or there is the stretching of the perineum is there, then you give the episiotomy if needed. Usually if the multi-patient, a small baby, there is no requirement of episiotomy, but if is a primary patient and there is the soft tissues are very tight, then you can perform the episiotomy. Now let the buttock deliver. बिल्कुल कुछ करने की जरूरत नहीं है, अपने आप बटक को deliver होने दीजिए. Don't touch the baby till the scapula, inferior angle of the scapula is visible. Okay. And now if it is flexed big, so usually the lower limbs comes with the delivery of the buttock. But if it is extended breech, sometimes it is extended, the limbs are higher. So don't pull the baby. As soon as the whole of the buttock is delivered and the scapula is visible, by putting your 2 fingers in the popliteal fossa and press it, the knee will flex and abduct it, then the ankle that footling will fall. You hold the footling and bring down. The simple bringing down the leg is not. Don't pull and don't do that anything. Simple after delivery of the complete breech. In case of extended breech, simple you are pulling, bringing down the leg by pushing the popliteal fossa, abduction movement, and by this the footling will fall. And you can hold the footling and bring it down. So after the delivery of the body, you are seeing that is the lower angle of the scapula. Now till the scapula, you have seen that the body is delivered. Now you see the medial border of the scapula. Medial border of the scapula means if it is winging. आप अपना हाथ उठा के देखिए, अगर अभी hand extended है, in that case the scapula will be winging. By that you will know that the hands are, that is the upper limb or arms are extended or flexed. So if it is flexed, there is no problem. By simple hooking method, you deliver the anterior and posterior and thereafter the head. But when there are the extended, in that case by the simple hooking method, it will not come. In that case, you will deliver the limbs, arms either by the love set maneuver or by the classical. So how will you deliver the extended arm? For the extended arm, I will demonstrate after this lecture. For the extended arms, I told you how will you diagnose? By seeing the medial border of the scapula. For the extended arms, Lapset maneuver, you hold the baby at the femoropelvic grip, at the femoropelvic junction. Your thumbs should be parallel to the spine. Okay, and thereafter you push the baby towards the medial side of the mammoth, towards the abdomen of the baby, and then slightly lateral traction, and thereafter you rotate the baby by the 180 degree half circle. keeping in mind during rotating, back should be the anterior. So the posterior shoulder will come anterior. So this is the principle of Lupset maneuver or classical maneuver is deliver the posterior shoulder first. And in Lupset, bring the posterior shoulder anteriorly and it will deliver out. That is the Lupset maneuver. For the delivering of the second arm, rotate the body another side, it will come out. That is the Lupset maneuver. When I will demonstrate, you will be understand. If the left side, there is no chances of rotation, then what you will do? That is the classical method. In that, you will put in your hand in the sacral hollow, go up to the posterior shoulder, and arms go up to the elbow, and slip the hand over the face of the baby and deliver the hand. When the posterior arm is delivered, usually the anterior arms delivers spontaneously. Otherwise, by the simple hooking method, you can. Now, what happens? Nuchal displacement. Nuchal displacement means baby का hand जो है occiput के पास चला गया and it is behind the occiput. In that case, क्या करना है आपको? You rotate the baby towards the direction of the finger of the hand by the 90 degree. So what happens when it is on the? You are rotating the baby 90 degree. Your hand, this hand will be slipped out, and it will be dead. That is for the nuchal displacement. When the hand is, there is the nuchal displacement that is not extended. For the extended, Lupset method or classical method, deliver the posterior shoulder. Now the delivery of the after coming head. After the delivery of the arms, either you can deliver the after coming head by the Bun Marshall technique or by the Morrissey-Smalley maneuver, that is the jaw flexion and shoulder traction, or by the application of the forceps. So the Bun Marshall, if the patient is in spontaneous labor, everything is delivering spontaneously. In that case, to hang the baby on its own weight, not more than 2 minutes. As soon as the suboccipital region is nape of the neck is visible, hold the baby's limb, and by making the arc, you can deliver. So that is the Bun Marshall. So when you are doing the assisted breech delivery, the Bun Marshall is not working. In that case, you use the Morrissey-Smalley maneuver, and that is known as the jaw flexion and shoulder traction. In this, you keep the baby body on your forearm and 2 fingers on the malleolar prominence. That is the malleolar prominence. And the other hand, the 2 finger on the right shoulder, middle finger on the nape of the neck, and the index finger on the that is the left shoulder. And by this hand, you are giving the traction, and by this hand, which is on the malleolar prominence, you are maintaining the flexion. That is the jaw flexion and shoulder traction. Deliver it by the flexion. So in the breech, head is delivered by the flexion. And as soon as when you are giving the traction, as soon as the mouth and nose is visible, then extend the body. The body will be delivered. Now it is not coming with this, then you can apply or you can apply the forceps. Remember, for this, never use the release forceps or outlet forceps. For the forceps delivery of the after coming head of the breech, we use the low forceps. I will show in the demonstration that is what is the low forceps. For that, you wrap the baby body in a towel and ask the assistant to hold the baby. Then you underneath the baby, you apply the left blade, then right blade, lock the blade and give the traction horizontal, forward and upward. That way, the main purpose is you are flexing the head and delivering the head. So this is the after coming application of the forceps on the after coming head. After the delivery of the baby, active management of third stage should be done, and thereafter you have to explore the cervix and vagina for any trauma and tear. Then stitch the episode. Now, what are the complications? Because there is the assistant here, the internal manipulation, and the complication. There are the complication to mother and baby, to both. The complication of breech presentation and delivery is the cord collapse. So that's why early rupture of membrane should be avoided. It is most common. This cord collapses in the incomplete breech. That is the frank breech. This is the flex breech and footling presentation and knee. It is most common. Birth trauma to result of extended arm. You are doing the manipulation. There may be the fracture of humerus, fracture of the. You are giving the traction on the shoulder. That is the stretching of the brachial plexus, so facial palsy, and that can occur. Or if delay in the delivery of the head, that is the birth asphyxia. Or there is the quick delivery of the head that can lead to the intraventricular hemorrhage. So the asphyxia from the cord collapse, cord compression, placental detachment, and the arrest of the head. You are holding the baby, so hold at the femoropelvic junction, not give the pressure on the abdomen. You are giving the traction or holding the abdomen. In that case, there may be the damage to the abdominal organ or broken of the neck. Broken of the neck means there is the stitching of the nerves and the cervical fracture on this can be occurred. So be gentle for the delivery of the head. So emergency care of the whenever the patient comes in the emergency, what you will do? Review evaluation of the mother's condition, auscultate the fetal heart sound, membrane is present or not. If the membrane is present, patient is an early labor, then you refer to patient the district hospital or the medical college. If the patient fully dilated, now you cannot transfer this patient. In that case, you deliver the baby as I do. So thank you for this is for the breech delivery. So now the second talk is on the shoulder dystocia, that is very emergency. So what is shoulder dystocia? Shoulder dystocia means the delivery of the head is happened. There is the arrest of the shoulder. सर डिलीवर हो गया, अब शोल्डर नहीं निकल रहा है. Normally क्या होता है, after delivery of the head in the normal labor, after delivery of the head, shoulder usually delivered in 24 to 30 seconds, not more than that. So when there is no delivery of the shoulder for more than 60 seconds, it means it is shoulder dystocia, that is the shoulder is arrested under the pubic symphysis. It's a very emergency, and it is in this the perinatal mortality is more, and it is more common in the diabetic women. Why? The diabetic women में क्या होता है कि head तो small होता है, but the fat is on the shoulder is larger, so some head will deliver easily, but the shoulder arrested, that is the shoulder dystocia. The other causes of shoulder dystocia जब हम पढ़ते थे तो उसमें बताया था dope word. Dope means D is diabetes, O is the obesity, obese woman, ठीक है ना. P is the post mature, क्योंकि post mature बच्चे भी बहुत बड़े हो जाते हैं. And E is the excessive weight gain. अगर women में excessive weight gain हो रहा है, so these are the risky women where the shoulder dystocia can occur. So the diagnosis, when the lapse of more than 60 seconds after delivery of the head, shoulder is not delivered. Usually it is impacted anterior shoulder under pubic symphysis, but the both shoulder can arrest, that is on the sacral promontory, posterior on the sacral promontory and the anterior under the pubic symphysis. So क्या होता है कि after delivery of the head deliver हो गया है, और जब आप पुल कर रहे हो छोड़ देते हो तो हेड रिसीड बैक करता है, जस्ट लाइक ए दिस टर्टल. हेड जो है उसके कवच जो कवर है उसके अंदर रिसीड, तो हेड इज रिसीडेड बैक ऑन द पेरिनियम, एंड दैट इज नोन एज द टर्टल साइन, दैट इज द रिट्रैक्शन ऑफ द हेड अकर्स. आप पुल कर रहे हो, आप छोड़ देते हो तो द रिट्रैक्शन ऑफ द हेड इज दैट इज नोन एज द टर्टल साइन. So it is a very emergency For that, you call for help and note the time of the delivery of the. तो नोट द डिलीवरी ऑफ दैट, क्योंकि शोल्डर डिलीवर होने के लिए आपको 5 मिनट से ज्यादा टाइम नहीं देना है, तो जितने भी मैन्युअर करने हैं विद इन 5 मिनट्स आपको करना है. आस्क द वुमन टू स्टॉप बेयर डाउन, उसको बेयर डाउन नहीं करना है, इमीडिएटली पेशेंट को फ्लैट लेटा देना है. होता क्या है, नॉर्मल डिलीवरी में हम हेड एंड रेस करके रखते हैं, तो इमीडिएटली पेशेंट को स्ट्रेट लेटा देना है. एंड आस्क दैट डोंट बेयर डाउन. Ensure if the bladder is full, bladder is empty, should be empty. And if episiotomy is not given, if it is required, you give the episiotomy, because sometimes by the giving the episiotomy, it increases the space, you can deliver the shoulder. So these are the mnemonic. You can remember that alarm, ALARM, means first you ask for help. Emergency you cannot manage alone. So call for help. जो भी आपके पास स्टाफ नर्स है, जो भी आपके पास दाई है, जो भी आपके पास वर्क है, call for help. Then जैसा मैंने बताया कि you lie the patient flat and lift the buttock and legs. That is the flexion at the hip joint, flexion at the knee joint, and abduction. And give the episiotomy, and then you give the traction. By this, if it is not delivering, then the another manner, rotate it obliquely or supra-pubic pressure, that is the A. Or if it is not coming, then you can do the other maneuver, that is the Wood's maneuver, I will tell you. And if it is not delivered by this method, then you do the manually remove the posterior arm first, or you can ulta lady ko lita diya, hand and knee par, and then you can deliver it. That is the alarm. Now there are other mnemonic that you can remember. That is the helper. इसको अगर आप याद रखोगे तो helper से आपको क्या आता है? सबसे पहले call for help. अगर head के बाद shoulder नहीं आ रहा है, immediately evacuate the bladder, and if it is full, and evaluate for the episiotomy. If it needed, give the episiotomy. Then the Mac-Roberts maneuver, L for legs, means as I told you, flex the leg at the hip joint, knee joint, and abduct it. Thereafter, you give the P is for the suprapubic pressure, E for enter, मतलब आप जाइए enter करिए and rotate it, or you do the Wood's maneuver. इससे भी नहीं आ रहा है, then remove the posterior arm first. And the last is the roll the patient to her hands and knees. And this is the mnemonic, that is the helper. By that you can deliver the shoulder. So taking one by one. Now what is the Mac-Robert maneuver? This is the hyperflexion and abduction of hip. This is the initial maneuver. जैसा कि you can see this in this picture. There is the flexion at the hip joint and flexion at the knee joint, and woman is lying flat, and this is another picture. This is the simple, safe and effective method. If you are doing this, more than 40% of the shoulder dystocia can be delivered by this. And this is the picture is showing, that is first you give the Mac-Robert maneuver, thereafter you give the suprapubic pressure simultaneously. Both can be given simultaneously. And the other person is giving the gentle traction on the head. So these three processes when you done, then it is the 90% of the delivery can be up. So this picture is showing, that is there is the flexion of this. There is the flexion of the hip joint and flexion at the knee joint, and by the other hand this lady is giving the suprapubic pressure. Same here is shown, that is the flexion, and there is the suprapubic pressure. The suprapubic pressure should be given towards the back of the baby. Towards the back of the baby, the purpose of this is decreasing the shoulder diameter. The shoulder diameter, this acromial diameter decrease हो जाएगा, and one person is giving the traction downward, then the baby can be delivered. So the combined Mac-Roberts maneuver with the suprapubic pressure resolve the most shoulder dystocia, more than 90% shoulder dystocia deliver. When this maneuver fails, then another maneuver is the rotate anterior shoulder by moving obliquely. But it is impacted, sometimes it is very difficult. Then what you will do? This is the Dupin's maneuver. In this, insert your 2 fingers in the vagina and go to the posterior aspect of the shoulder and press it. Press it so that there is the posterior aspect of the shoulder and push it towards the chest of the baby. तो उससे क्या होगा कि the diameter of the shoulder will decrease and that will be disimpact from the shoulder will disimpact and it will be delivered. And that is known as the Rubin's maneuver. By this, if it is not delivering, then you can do the Wood's cork maneuver. Wood's cork maneuver में क्या है? एक हाथ आपने anterior shoulder के posteriorly लगा दिया, दूसरा हाथ जो है posterior shoulder के anteriorly. दोनों के pressure से you are trying to move the shoulder, and this is the बिल्कुल जैसे cork घुमाते हैं. You are trying to move the shoulder. That is the Wood cork maneuver. By this, the shoulder diameter will decrease, and simultaneously you are giving the traction on the head. Shoulder can be delivered. So try that. उससे भी नहीं हो रहा है, then you try to deliver posterior arm. If it's still not delivered, turn the woman on hands and knee. Again try to deliver posterior shoulder. If the fetus is dead, deliver it after doing this. So if the shoulder is not delivered by the macrobot, suprapubic pressure, Rubin's by the giving the pressure on the shoulder, Wood cork maneuver, then you try to deliver the posterior arm. This picture is showing that is how to deliver the posterior arm. Put your hand in the sacral hollow, go up to the posterior shoulder and try to bring this posterior arm. And by holding the arm, you are bringing down the sweep over the chest and deliver the posterior arm. When that posterior arm will deliver, then of course the diameter will be decreased. You can deliver it by the traction, the anterior arm will be delivered. So this is the try to deliver posterior arm. उससे भी नहीं हुआ. That is the last. Put the patient on hands and knees position. उल्टा कर दीजिए उसको. Hand और knee position में कर दिए. Now give the traction. You give the traction downward. This is the head impacted. You are giving the traction downward. Now this is the posterior shoulder. It will deliver first and then the second. This is the hands and knees position for the delivery of the shoulder. In spite of that, all fails. That is the. तो इन सब चीजों में 2 से 5 मिनट नहीं लगता है. एवरी मैन्यूअर के लिए आप जो है 30 to 60 सेकेंड, नॉट मोर देन दैट. यूजली 90-95% मैक्रोबर्ड एंड सुप्राप्यूबिक प्रेशर से, तो आपको मैक्रोबर्ड एंड सुप्राप्यूबिक प्रेशर कैसे देना आना चाहिए. एंड इससे भी नहीं हो रहा है, देन यू कैन फ्रैक्चर द क्लैविकल. इफ द बेबी इज डेड, you can do the cledotomy. Cledotomy means after fracture of the clavicle. That is the last maneuver. So what is the after the delivery of the baby? So all important thing क्या है कि head कब deliver हुआ है उसको note करना है. आपके साथ जो आपने call for help किया है उसको note करना है. There are what happened, what are the maneuvers you have done. You have to return what time it is taken and at what time the baby is delivered. That is very important. After delivery of the baby, perform the active management of third stage of labor. I know you are knowing that is after the delivery of because this is the prolonged labor and chances of PPH is there. So for the prevention of the PPH, you are doing the active management of third stage of labor by after the delivery of the baby. You give the 10 units of oxytocin intramuscular when the uterus is contracted, then deliver the placenta by the control cord traction method. So be alert for the PPH. Itni der ho gayi hai, there's the chances of atonic PPH, and you are doing all the manual, there's the chances of traumatic PPH. Both can occur in this patient. Assess. So always after management of the active management of third stage of labor, assess any cervical tear, vaginal tear, extension of the any episiotomy, perineal tear, that should be taken care. Assessment of fetal well-being by because in this patient there is always in the breech and the shoulder dystocia, resuscitation is required. So in all cases, you have to prepare for the resuscitation. Means कुछ भी नहीं है तो कम से कम oxygen, suction, AMBU bag, and if pediatrician is available, that is the best. Counseling of the patient and family must be done. What happened and what you have done, what you have written consent should be taken. Events of the delivery must be documented by all care team. ये नहीं कि आप ही को सब करना है, कोई भी है उसे को टाइम नोट करता जाए, कितने बजे हेड डिलीवर है, कितने बजे शोल्डर डिलीवर, व्हाट आर द थिंग्स यू हैव डन, बिकॉज इट इज अ मेडिको लीगल हो जाता है. बच्चे में पेरीनेटल मोर्टेलिटी एंड मॉर्बिडिटीज आर वेरी हाई इन दीस केसेस. So what are the complications of shoulder dystocia? Fetal complication, maternal complication. Perinatal अगर जितना भी डिले होगा उतने चांसेस ऑफ स्टिल बर्थ के हो जाते हैं. तो पेरिनेटल डेथ्स आर वेरी हाई. और देयर इज द वी आर गिविंग द ट्रैक्शन ऑन द शोल्डर हेड. देयर इज द स्ट्रेचिंग ऑफ दिस brachial plexus that can lead to the various type of the nerve injury, or there is the iatrogenic clavicular fracture, or you are doing the manipulation, fracture of the humerus can be occur. And maternal death maternal complications are postpartum hemorrhage. Postpartum hemorrhage due to atonic PPH, due to due to the traumatic. So there must be, you are pulling the baby, you are giving the all the manure, but sometimes there is the perineal tear, and this tear can extend up to the 4th degree. So these are the complications of the shoulder dystocia. So the shoulder dystocia usually occur after delivery of the heart. So observe the high risk cases. As I told you, that it usually occurs in the diabetic movement, and sometimes it is mismanagement of the labor. Mismanagement of labor in twin delivery, that can also lead to the shoulder dystocia. Thank you. Thank you for patience listening about the shoulder dystocia.